have to be addressed according to the need in every situation. The reason is you have to take intraoperative decision to ensure that your topicals are reaching adequately to the area where you want and they are not coming in the way. If they are coming in the way and becoming the site of obstruction, you have to address them.
Right, sir.
That's an intra. But if they are obstructing and if you are not treating them, it's a disaster. It can lead to an ultimate failure if your topical do not reach there. So it's a very, very important part of the surgery.
So in terms of debriding the medial polypi, what counseling will you do with the patient with respect to loss of olfaction? Also with respect to chance of exposure of the olfactory fibers or CSF?
Yes. So first of all, your question is valid and I have already told certain things. In this region, you are not going to do anything to the olfactory mucosa. That I will show you. Olfactory mucosa is there in the upper part of the septum, upper part of the superior turbinate, and uppermost part of the medial surface of the middle turbinate. So those areas we are not going to disturb with debrider or anything. Whatever bulky polyp or anything projecting into that area, we will debride. But the mucosa from that area has to be left untouched. If you try to do anything, you will end up giving fibrosis and that is disaster.
Right,
Even
sir.
if there are some polypoidal mucosa left, and if you have given an avenue for the topicals to reach there, it is bound to revert back to normal. You don't have to be very aggressive in the olfactory recess as far as the surgery is concerned. This is
Right, sir.
important point to preserve olfaction.
Sir, and in the morning you had said about this central compartment disease in which there is laminar flow of the airflow along the turbinate. But
Yes.
if we do a resection
Yes.
of the turbinate, as you just said just now,
Yes.
will it affect the this laminar flow
Yeah.
again?
Not laminar. That doesn't affect the laminar flow. Rather, it opens up other areas for the allergens to deposit. It's not that it affects the laminar flow. It
Okay,
opens up other areas to be affected.
okay,
So
okay.
here, in this case, turbinate, as I said, turbinate and septum requires correction to prevent coming in the way of the topicals. Here, you see the both the turbinates. One is a concha, one is a lamella, and they are going to be unstable once you remove the disease from there, and they are full of disease. So in this situation, you have to do a partial resection. You are left with no choice to, any other choice. So you have to do, and we'll follow such patients with the proper anti-allergic treatment, immunization, and close follow-up. More effective, maybe more long-term irrigation and all that to deal with anything coming like that. But we cannot help it. Looking at the turbinate situation, we have to deal with it. Generally, as a principle, as much as possible, you don't remove the turbinate.
Hello, sir. Sir,
Yes.
before going for surgery, for how many days you should give a medical trial for this patient?
Such patient, yes. I mean, these are the patients who present with olfaction loss. I told you certain gray areas. And this is another gray area where the disease is so severe to have given a major symptom of olfaction loss. This is major symptom. I had given you the list of symptom major and minor. This is one of the major symptom. Means disease affecting the olfactory cleft, eosinophilic disease, associated allergy. So it has to be aggressive. Yes, obviously, in such patients, as a medical treatment, you should try full adequate medical treatment. But that is only with a saline irrigation and nasal spray,
Okay, thank you,
which
sir.
is with such a big symptom olfaction loss, it is unlikely to resolve. Olfaction is a major loss.
Okay, sir.
Now, such patient ultimately requires surgery.
Okay.
You have to be sometime practical. When some patient is coming with a massive polyp, nobody can cure with the medical treatment alone.
Exactly.
So we are starting the case in couple of minutes now.
Right, sir.
We can continue the question, discussion, anything. Please come out with any suggestion, questions, or anything related to FESS in this 2-day workshop, entirely dedicated to this topic. I don't want anybody, keeping any doubts in the mind.
Sir, in case of osteitis, do we find it difficult to find the maxillary sinus opening? I mean, what are the difficulties that we can face
Yes.
in finding the maxillary sinus ostium?
Yes. So that's a very important question. Not only osteitis, but in many other situations, you may find difficulty in sinus openings. Not only maxillary, frontal, anywhere. Or you can take it like revision situations. Osteitis is also, and revision situation is also. So, as I said, this is a surgery of landmarks. There are certain landmarks which are rarely destroyed, and use them as a preferential landmarks. Like, for example, like you asked for the maxillary sinus, inferior turbinate is a landmark which is rarely destroyed. So, like in this case, I use the inferior turbinate as a landmark, and just above the superior surface of the inferior turbinate, I went inferolaterally to open up the maxillary sinus. So, inferior turbinate is a great landmark for the maxillary sinus, number one. Sometimes in revisions, you have already maxillary middle meatal antrostomy and you have to open up other sinuses like frontal or anything. Middle meatal antrostomy itself is a great landmark. Following that, you can see the lamina easily above the middle, maxillary antrum. Above and medially is the lamina, above is the orbit, and medially that is lamina. Following the lamina, you go to the beak. Even if you don't have turbinate, once you find the lamina and beak, follow them where the beak ends in the frontal. And follow the skull base, you can see the sphenoid. So by one landmark, you can go in and, find other sinuses. Why I mentioned all these structures, beak is rarely destroyed in spite of multiple revisions, unless, the draft is done. In regular sinus surgery, beak is never destroyed, so you can always use it. Like in this case, you follow the beak where it ends in the sinus. Similarly, for behind, there are certain landmarks which are always present, like coina. Coina is never going to go anywhere. So if you see the coina behind, staying close to the septum, 1.5 to 2 centimeter above the coina is going to be the sphenoid. Once you find the sphenoid, find the skull base behind the sphenoidal skull base and follow it anteriorly, you can reach to the frontal. So by one landmark, one reliable landmark, reliable means inferior turbinate, middle meatal antrostomy, frontal beak, coina. These are the landmarks which are never destroyed. By using a single landmark, you can accomplish the entire sinus surgery. That is so important. Is clear?
Sir, sometimes in this middle meatal androstomy, we find the bone around is very thick and hard. So,
Bone around in osteitis.
So, but in how do we pick that up in a CT scan, the thickness? Because sometimes it's mostly very easy to find the middle meatal androstomy following the uncinate, but when the whole area is hardened, thickened, and
Yes.
how do we?
Is that a revision situation you are talking about?
No, sir, not revision, primary case.
See, primary situation I mentioned earlier. Primary situation I had mentioned earlier, osteitis rarely involves primarily the dependent sinuses. Osteitis first, foremost, and most often involve the ethmoidal septations. You may find very hard bone in the ethmoidal septations to remove, but rarely a hard bone in the maxillary sinus or anywhere region. You know which bone you encounter to open the maxillary sinus? Uncinate. That's the only bone come in the way because anterior limit is your nasolacrimal system. Posteriorly is your perpendicular plate of the palatine bone. The only bone which need to be removed, address is uncinate to open up the maxillary sinus. And uncinate is never involved in osteitis. Osteitis, I told you, first, foremost, and most often involve the ethmoidal septation. Very thick septations, you have to really use a bone punch to remove them, because that is full of neosteogenesis because of the ongoing inflammatory disease. इसको भी रख लो कल के लिए ना कौन सा अच्छा ठीक है चलो। So any other questions? We are moving to the next case. ये ऑन करा सा माइक, इसका वॉल्यूम आ रहा है क्या? इसका वॉल्यूम हेलो